Hi, everybody. Peter Weimersheimer. I'm the VP of Education and Clinical Implementation at Butterfly Network, and joined by my great colleague, Devinder Ramsingh, who is a cardiac anesthesiologist. And we're hosting another POCUS Power Hour. And these monthly sessions have been designed to showcase different aspects of point-of-care ultrasound and how it affects clinical practice, and also have discussions about how to even start doing point-of-care ultrasound in different types of specialties. And really looking forward to this evening. We have some international flavor here, some amazing clinicians who will be doing point-of-care pre-hospital ultrasound over the globe. We have Ben Tal from Vienna, Austria, and John Barrett from the UK, and Tom Jellick from Canada. So I think, Devinder, I think you and I are the only locals here.
That's right.
But just all have been really active in a lot of pre-hospital training and implementation, just frankly, clinical use of ultrasound in the pre-hospital environment. So like all the other webinars we have, this is going to be conversational. We're going to have a chat session open. Please type in questions. We'll try and get to them in real time. And if we can't, we'll follow up with you and make sure we answer the questions. So really hope to have your engagement and have your input about things that you're interested in hearing with our outstanding experts visiting in tonight. So with that, I'm going to start. And Ben, you're right here on my upper left, so you're first. I would love to have you introduce yourself and talk a little about your background and something about pre-hospital ultrasound that you're incredibly passionate about. So thank you all for joining, and looking forward to this.
Yeah, good evening, everybody. My name is Ben. I'm sitting in Vienna in Austria, which is the capital of Austria, basically. And I'm with Vienna EMS, which is like the main EMS service here in Vienna. We have I guess about 300 paramedics per shift that are on duty and covering the whole city area. And I'm there as a senior physician, and yeah, I'm responsible for implementing ultrasound within our system, and also responsible for ultrasound education. And yeah, apart from that, I have 2 kids, and I love flying a little helicopter in the Alps in the wintertime, and love diving. And of course, I'm an ultrasound geek, I guess.
Sounds great.
Great combo.
So John.
Hey, good evening.
Yeah.
Thanks, Peter. So I'm John Barrett. I'm a, as US people would call, board certified physician in both emergency medicine and pre-hospital emergency medicine. So that's a sort of subspecialty within the UK of emergency medicine. So I work with the East Anglian Air Ambulance, which is a HEM service in the east of England. We operate with 2 EC-145 helicopters out of 2 bases, and our population is probably around about 5 to 6 million that we cover over a fairly big geographical area. Yeah, I sort of got interested in POCUS because I was sort of challenged because our service, we run a critical care service, and we sort of deeply analyse all of our pre-hospital jobs, but ultrasound was an area that we had as a capability, but we weren't sort of necessarily analysing to the same degree of depth. And I got sort of challenged to see how we could improve that, and that's what started my sort of journey around implementation of POCUS into our sort of pre-hospital critical care system. So that's been a really exciting sort of few years. I think probably started out on it about 6 years ago, and we are here now. And then the other thing that is my other sort of big interest is around endovascular resuscitation. And as anyone who's interested in that area knows, it's all about the access, and that's always ultrasound guided. So yeah, that was then what I've now spent the last sort of 3 years focused on, both my clinical and research aspects. So what's interesting about me, I actually don't live in the east of England anymore. I live in an area called the Peak District, which is a sort of semi-mountainous area in England. And I've got 7 chickens at home, so that's my sort of interesting fact. So a bit of a semi sort of farming lifestyle as well.
A 7 chicken farm.
Yeah, ish. Just starting out.
And Tom, you're coming from at least this continent. And
That's
something
right.
that's
Yeah,
always
yeah,
been
at least I'm
always
in
been
North America.
fascinating about your involvement with pre-hospital medicine and air medical is you're very passionate about the need of the region you're in, where it's much more sparse and there's a lot of areas where they have no resources or imaging at all, and how
Yeah,
you've really tried to expand that space by being creative with adding ultrasound onto your transport system. So
for sure. Yeah, yeah,
thanks for
yeah. So
joining
my
us.
name's yeah, no, thanks for having me here today. Yeah, my name's Tom Jellick. I'm based out of Winnipeg, Canada. For those of you who are not familiar with the geography of North America, we're kind of right in the middle of Canada, landlocked. I'm one of the transport physicians and the ultrasound director for STARS Air Ambulance. We operate 6 medical bases across Western Canada. And our journey, similar to John's, also started about 6 or 7 years ago. At that time, it was a physician-only skill, and we quickly identified that there was a lot of eye rolls from pilots when we asked for the ultrasound to be uploaded, mostly due to weight issues and whatnot. And we quickly kind of tried to kind of conceive a way to have our air medical crews, which are mostly nurse and paramedic based, how we can train them up. So we started with a small proof of concept, essentially, of 12 air medical crew, and quickly extrapolated now. Except they keep hiring people, which is probably a bit of a downfall. But we've as of 6 months ago, we had everyone trained up, at least in some core competencies that we defined. So yeah, this is a huge area. Again, if you're not familiar with Canadian geography, we, at least where I work, we operate a fixed wing and a rotor wing asset for critical care transport. Our transport times with fixed wing can range anywhere from an hour up to 2.5 hours in the far northern reaches of our province. And with that isolation comes a lack of any diagnostic tools, really. So a lot of nursing stations or small rural hospitals might have an X-ray machine, and often after 4 p.m. there's no one to operate the X-ray machine. So ultrasound is the only method to make diagnoses and manage your patients. So yeah, we kind of bring a bit of a unique environment to something that's a little bit different compared to our colleagues in Europe.
Just to go forward on that, just a hair. One of the things is if you look at literature on pre-hospital ultrasound, it's relatively sparse, and clearly here you are going to areas where you're taking ultrasound maybe as the first diagnostic tool on your patients. A sense of how often or what that means in terms of change in management or adjustment of management as you've implemented the program, or as you've had more on board who are actually using it more frequently in transport?
Yeah, we found pretty quickly that many of the times things weren't as advertised, mostly because you had no method or mechanism to correctly identify. So it's, we have probably, you want to say, maybe 75 cases over the past couple of years, where there's been, destination changes as a result, where you go for a patient with undifferentiated shock and diagnose that they have a AAA, or have the unexpected pneumothorax and, a blunt trauma patient that you weren't expecting. And so there's been kind of changes like that, destination changes. In some of our provinces in Alberta, we've actually incorporated where the crew can activate massive transfusion protocols pre-hospitally without the patient physically being present in the ED. And we have actually in Calgary, Alberta, they actually have a hybrid operating theater where they operate, general operating theater, but also an endovascular suite. So if you have an unstable patient with a positive free fluid in the abdomen, for example, they can divert directly to the theater rather than stopping in the ED. So again, it's those small incremental changes that I think ultrasound played a pretty pivotal and cornerstone role in kind of pushing the envelope of what we can do, and kind of provide that more definitive, more rapid care for our patients.
Peter, I'll piggyback off that discussion, and Tom, and love to get the rest of the panelists' thoughts on this. That, is the first approach for ultrasound adoption in the EMS setting of the FAST exam? Is that where you saw the first utilization, or where did it start? If you could comment, because again, we have such a great diversity in your practice care settings. Would love to see, just to kind of get a little history on how it started, with what topics, and where has it gone to today?
I don't mind sort of taking that up a bit. So yeah, I mean, for our system, it sort of reflects the nature of the jobs that we attend, and we do, well, probably near enough 99% of our cases are scene attends. So we don't do very much inter-hospital transfer within the service that that I work in. We've got a ground service that sort of does that workload, but the HEM service tends to go direct to scene, and actually a large proportion of those patients, up to sort of 50%, are out of hospital cardiac arrest. So that's then reflected in the ultrasound data for our services that it reflects what the proportion of patients that we attend are. So the data that we've got suggests that the vast majority of our scans are to help with prognostication and identification of reversible causes in cardiac arrest, and that's more a reflection on the types of the nature of the scene attends that we go to than anything else. And then it's followed up with EFAST lung scanning, and then some other sort of niche areas, such as very occasionally we might do a scan looking for aortic aneurysm. And then that's the diagnostic side, and then we've also got the therapeutic side in terms of how we're utilizing ultrasound for procedural use. So and in particular our work around the endovascular stuff, it's all with regards to femoral access, which without ultrasound, you as I said at the beginning, you just can't achieve. So we sort of split it into those two components, but it very much just reflects the nature of the incidents that we attend more than anything else.
One of my questions about pre-hospital cardiac ultrasound. So there's prognostication, and then there's certainly the noise, at least from transesophageal echoes in the A&E, about adjusting hand position and changing CPR. Is that something that is part of a protocol that when you're in the field that you're doing that as well?
We have found limited ability with transthoracic echo to be able to necessarily make significant changes with position, either with mechanical CPR or manual CPR, but we tend to then augment that with our femoral arterial invasive blood pressure data to give us a sort of more of a nuanced approach. I agree with you, transesophageal probably would identify those cases where there's left ventricular outflow tract obstruction, which is something that we're keen to sort of potentially pick up. Also seeing a large number of pericardial effusions in the context of prolonged resuscitation attempts, and we're not sure of what the significance of that is. What proportion of those was the cause of the out-of-hospital cardiac arrest versus potentially an iatrogenic effect of sort of prolonged resuscitation. And then it's difficult in a non-contracting heart necessarily to always understand whether there's true tamponade as a result of that pericardial effusion or whether it's just fluid around the heart. But yeah, it's an interesting area.
And just to piggyback, I think maybe this is the not so sexy side of pre-hospital POCUS, but that ability to terminate in the field is a pretty powerful tool. So the decision not to transport a patient is probably just as critical, right? Rather than flying that post-arrest to the patient that's incredibly tenuous, that's likely going to arrest, and doing chest compressions at the back of a helicopter and airplane is not fun. I don't recommend it. But again, that's a pretty powerful tool, right? As well, and something that maybe again less sexy about it, but I think it's another important factor to consider.
Yeah, I completely agree with that.
Absolutely, especially when it also comes to ECMO, for example. If you ever call it, I just remember 2 weeks ago we had a case where we were called to a 40-year-old witnessed cardiac arrest from a previously healthy individual, and it was only a quick glance in the very early stage of the whole resuscitation where we figured out that this guy had a big pericardial effusion, also with a tamponade, and that's where the decision was made not to transport him and to cancel ECMO. I mean, which is saving thousands of euros in the process. And this is, for example, something I've never heard anyone talking about, that it can also prevent costs or higher costs in down the line when you decide to just abort a resuscitation because it's just fulminant,
Yeah, we've added that into our protocol for a sort of pre-recruitment scan for REBOA in medical cardiac arrest, and now we include that scan to rule out a big pericardial effusion suggestive of aortic dissection, because we don't want to be recruiting those patients into our study if that's what the underlying pathology is. So yeah, and it's a quick scan you can do, right? So it doesn't delay anything significantly, but stops potentially recruiting a patient that's unlikely to benefit from an intervention, whether that's REBOA or ECPR. So, yeah, I think that's a really important finding. It's hard to measure though, hard to then sort of say what's the benefit is a benefit of not doing something, which is so much harder to sort of quantify and sort of find the sort of outcome benefit in something where you stop doing something rather than when you do something as a result of the finding. It's much harder to measure, I think.
Although, frankly, I'm in Vermont, a rural area, so we have very long transport times, and the decision to not transport is pretty profound for lots of different reasons. So having that skill set definitely has I guess to your point, Tom, it's not the most fun topic, as sexy as all the other stuff, but it changes a lot of the costs and the work involved, and frankly the risk, right? When an ambulance is going code 3 in rural Vermont in February in an ice storm, it's probably nice to know that it's for a valid reason. Ben, I was going to talk to you a bit about training and what you see in Vienna. I'm going to quickly there's a question here from one of our listeners, Colton Amaral. Hopefully I said your last name correctly. And the question was for John, but all of you please chime in about, just for in the context of hand position, what are more common TTE views that are been used. So the question is standard sub-X and A4, or how do you modify your views for a critical patient with CPR or compression device? So just what are you doing?
Yeah, I mean, so we're using the Lucas mechanical CPR device. So I generally find it's fairly challenging to get any sort of reasonable sort of parasternal views alongside the compression cup, and most of our providers would probably do an attempt at a sub-xiphoid view, try and optimize that during the compression phase, and then with the minimum amount of pause, capture a clip, usually during the ventilation cycle, just to try and reduce the amount of delay and unnecessary period where there's no active compression phase, and then review the clip during the next phase of compressions. I think is probably how we would try to encourage our crews to use that. And it's one of the things that when we're reviewing the images offline, we're particularly keen to look at the potential delay and make sure that delay or period without active compressions hasn't been unduly long. So one of the things of being able to review the images afterwards through the cloud is then we can track to see that there hasn't been an unnecessarily prolonged period with no active compressions. But I don't know what the other guys' experience is of trying to optimize their views. But yeah, most of ours have been sub-xiphoid.
Yeah, I agree with that. It's it's next to impossible. And then we tried to upload a TE in our HEM system. That didn't work out so well either. So.
Future for one of Butterfly's mini chips to be a TE on a NG tube. Yeah, my dream.
That's cool.
So Ben, you're in a more urban environment. Similar types of use cases that you're doing, or what's your experience with what you see commonly, or how ultrasound is being used? And I assume relatively shorter transport times in general, or is much more or variable?
It's not an easy question, because I think you guys, especially in the United States, are a little more far ahead than we're here in Austria. We've implemented ultrasound in our physician-based cars 3 years ago, so it's still really young, and it's basically a very new technology in this country in the pre-hospital field. And if you try to implement it in 2024, you're still facing significant resistance, especially from the physician side, but also such as the legal situation that essentially only allows doctors to interpret an ultrasound image right to this day. And so we are just trying to find our way through the applications that we can roll this out. I mean, of course, there are big critical care scenarios, so such as CPR situations, severe trauma situations. But the thing that interests me especially is the everyday patient. You know, the one that is not bringing 5 or 6 different professions onto the scene, but the ones, for example, where 2 paramedics will just have to find out why this patient is suffering from dyspnea and stuff like this. And it's very hard because we're just starting to do studies, and you know, everyone is always asking for studies and data because we are the ones with the new technology which we will have to prove. But nobody ever asks whether, for example, how big is the impact of the stethoscope when it comes to transportation times, you know. And I think this is a topic that we will need to discuss. There is, of course, the big critical part and the decision making part of ultrasound in high risk situations, as we were discussing. Like John just mentioned, now it's getting even more specific these days with clamshell thoracotomy, with Reboa and stuff like that. And it's almost impossible to draw conclusions because those are situations where we still do not have enough cases to draw conclusions from it. So right now we just implemented our 4 main protocols, which is the EFAS, the CPR protocol. Then we have a protocol for dyspnea and of course for the chest pain. And but we base that around the common protocols that are in place, like the Rush exam and EFAST exam and the FATE protocol. And I think although these protocols have been developed within the clinic, they're a good starting point for the pre-hospital field. But I think especially when it comes to paramedics and people who are learning it from scratch, it really needs to be simplified at the start, to be then developed continuously. You know, because when I think of my own career, I didn't learn ultrasound from scratch in med school. I had to learn it by myself, and the biggest challenge I was facing, that I didn't have the time accordingly to my job or besides my job to train and just to take the probe and to put it onto the patients as a newbie. And I think this is a thing that we will have to bring into the head of our paramedics, that they will have to carry this probe with themselves around, you know, and just to throw it onto every patient that they're going to transport, like we use a stethoscope in the primary assessment. So there are different fields, and we're just trying to find our way how to implement.
Yeah.
Does that make sense, kind of?
100%, I think, and I definitely, Peter, let's definitely jump onto the topic of, you know, how do we go to implementation strategies and talking about training and the pitfalls. Well, I definitely want to get into that space because I know this is definitely an emerging area, and getting your guys' insights will be very, very key, I think, to our audience. We do have a couple questions though, and we're trying to make sure that we get to those to kind of keep the discussion going. And first question from Jacob is POCUS effective during a medvac, or should it be done prior to takeoff? Any insights there? Are you using it during the transport as well, or during the initial assessment?
Both.
Both.
It depends on your, I
Probably
think it depends on
different
the call,
strategies, right? Like what you're doing on scene versus during, you know, transfer.
For sure, right? And I think it also speaks to being cognizant of not delaying transport. So that was one thing organizationally that STARS was very paranoid about, was we're going to stay and be scanning people till, you know, we're blue in the face. So I think one thing when you're rolling out education is to be intentional of, one, scanning from weird positions, because you might be scanning in the back of a helicopter from the head of the patient, you might be on the patient's left, not from a standard right-sided position, or the right side isn't accessible to you because of the shell of the aircraft. And then conversely, being like, you know, do your normal job priorities, but if you have, you know, a 45-minute hour ride, things settle down, then pull out the probe and do it then. So I think it's very, very, very much dictated by what's going on and what priorities need to be dealt with.
Yeah, Ben, when you made the comment about stethoscopes and political pushback, which is always ironic given how how little information you're going to get in a stethoscope, even in a controlled environment. Right here, you're describing mid-flight in one of the more noisy, chaotic environments there is. But the concept of having a tool that you can actually do reassessments depending on the stability of your patient or the longitudinal trend of how your patient's doing, especially if you're, as you're describing, a 2-hour fixed-wing flight. That's not a static period of time. This patient's not going to hang out for a while and wait till they land before they change. So the concept you can have something that can get past the noise and the chaos seems pretty incredible. Yeah, there was a question from Shane on optic nerve sheath diameter. If those are being done routinely to assess, patients with ICH, potential ICH, is that for decision node on transport or just management? Is that something that's being done on your end?
I can speak to what we do. We were looking at rolling this out for our non-physician air medical crew. We do have kind of a handful of cases locally where we've done transcranial ultrasound, one to confirm diagnosis of ICH, but then use kind of the MCA Doppler, just the waveform, right? So nothing fancy, but just to see if that's blunted or not, and then kind of guide ICP management related to that. So yeah, the optic nerve sheath is in theory a little bit more simpler to do than TCD, and the thought was that it'd be something that we're working on introducing.
It would be really interesting to learn about the experience of trying to do TCD in those care settings. There's got to be some challenges, but great to see that you're trying to implement that. I know there's a group in the United States that's trying to launch an deployment with EMS environments and trying to see if it can be used for that assessment. And their proof of concept was developed in the inpatient setting, and now trying to bring it to the EMS. And I think you hit on all the points already of some of the challenges they're finding is, one, how do you do it without impacting transfer time and having about where they need to know where am I supposed to be going, and how much time do you allow to be able to allow that assessment to occur, and then do you put it during transport and slow down the potential for the ability to do an effective exam. These are all things that I think, to your point on that unique area, is something that we're all trying to fill out. It's great to see so many questions here, Peter. I think this audience is really looking to try to get some insights. Another question from Mike Orlando. Any advice for services? Oh, this is a good question. Any advice for services awaiting U.S. state agencies to expand the allowed paramedic scope of practice for ultrasound? So this is a U.S. focused question, but definitely, I'm sure across all our areas, we're encountering this. Our state only permits POCUS and cardiac arrest to verify cardiac standstill. We look forward to expanding to vascular access and EFAST. Is there any literature that could be submitted in support of expanding the paramedic scope?
Yep.
Yeah, and all of you have expanded from nothing to something, right? So you've got, in different, even globally, that there's that challenge of how do you go from the beginning in terms of what people are letting be functional or not. So
please go ahead, John.
I can pick that up. It's been a sort of area of big interest in our system. So just to give you a bit of context, the way we tend to operate is something called an interchangeable operator model. So it doesn't really reflect what your sort of professional background is. All of the tasks that we can undertake within the HEM service should be able to be done interchangeably by paramedic or physician, with the exception of driving the car on the blue lights. So, it's challenged around the ultrasound, like how are we going to make sure that the paramedics are trained to the same level as the physicians? And some of the physicians would come to the service with some pre-hospital training, but not always. So we put in place the pre-hospital training, standardized it across the entire service, and actually got to the point when we published our data where we were able to demonstrate, having sort of retrospectively reviewed the quality of the study, there is no difference between the studies recorded by paramedic providers and the studies recorded by physician providers. So if your colleague is out there looking for some data, I don't like doing this, I could suggest looking at the paper that we published that shows that, because that might help your discussions with your sort of state around there is some evidence base out there that suggests that these studies can be done as effectively, regardless of professional background, if you have a structured training in place prior to rolling it out.
I think that's kind of the same discussion that we experience in the airway training. If you have experience with 100 patients that you did where you performed an intubation, you're going to be proficient. And if you're going to train regularly and you keep up that skill with your 20 intubations a year, you stay proficient. And that's what we try to bring into the heads of the physician, that ultrasound is a skill, and the skill can be trained, and it can be very easily trained. It just needs good instructors, good training facilities. And I also always ask myself why everyone is thinking, just because we roll out ultrasound for paramedics, that we have to make everything very easy, you know. And yes, and maybe they will be able to detect a B line or an A line. I don't know. And I think in my experience that I've gained by training our paramedics, they can do the whole spectrum. It's just and that's this interchangeability that you mentioned. That is something that I think that is nowadays pretty specific to UK and Australia, because they are really far ahead in this way of thinking. But we just need this mind shift in the heads of physicians, that just because it was traditionally a physician skill doesn't mean that it has to stay this way. And now we have the whole artificial intelligence coming in, and it's getting easier from year to year. If you think of your handheld devices a couple of years ago, it's not 20 years ago, it's 5 years ago, they were trash. And now they're competing with the systems in the hospital when it comes to picture quality, image quality, and all the support tools, or that you can just jump in right in the same software into a training video. So we just have to bring probes out and into the hands of the paramedics and show them and take them the fear of using it on a daily basis.
Yeah, and sadly, go on. Go.
Sorry, yeah, just I totally agree with what John and Ben said. And I would just add in, the other saving grace from our end was our QA platform. So the ability to have that physician oversight, reviewing these images and providing feedback in a prompt manner, literally opened eyes, and we're like, wow, we're not even doing this in hospitals. You guys are doing this in the field. This is pretty wild. And that for us was a kind of a big push, that we're not doing this just kind of nilly-willy, and we're doing this and taking it seriously.
We went one step further as well, and we added a paramedic into our reviewing group. So it's 5 physicians and 1 paramedic. Yeah. So one in 6 weeks, the reviews would be entirely done by paramedic, and they'd be reviewing paramedic and physician studies and reporting on the QA. Once you get to that level, then there's no challenge, because you can say, look, you know, if you can demonstrate, you know, if your quality of scans are good enough, then you can even move to this top tier where you're in the faculty and you're reviewing the studies. And I mean, that was a really powerful step change for us to actually have a paramedic within that reviewing faculty.
And you were studying whether there was a difference in quality or level of review as you did that. Was there?
As in, we were reviewing then whether there was any difference between the quality reported on the QA process between provider, whether it was recorded as a physician or a paramedic. Yep. I don't think we've then done a second tier of review of whoever's reviewed them then being reviewed. It all gets a little bit sort of big brother.
Yeah. But
there's go on.
No, go ahead, Peter. Go ahead.
No, I was going to say, as we're talking about doing review and different strategies, there's a question on. Oh, just slipped. A question on, and I guess I'll start with you, Tom. But again, it's a concept of how do you set up a system for review, and it's a strategy for how to implement POCUS in rural areas. And when there's limited asks of the doctors and hospitals, which I think has been your system, but back to the concept of training paramedics when there aren't doctors or other people who are capable of doing.
I always kind of say it in jest, but like the critical care medics and nurses I work with are a lot smarter than I am. They're keen, they're brilliant, and very engaged group of individuals. And Ben and John, I'm sure you guys, agree as well. So there's absolutely no reason why they can't do this, right? They can intubate someone on someone's bedroom floor, where I can't do that. I need them in a hospital bed, right? So it's a little bit of I always say they got some skill sets. I think we're in a day and age where the notion that this is a physician-only skill is no longer valid. And I think with appropriate oversight and support, whether that's real-time teleguidance or delayed time feedback, there's no reason anyone can't pick up some bread and butter skills that'll help their practice, irrespective of where they are nowadays. So, for example, in where I work, we realize that cellular coverage in a lot of rural places is non-existent in some parts, but every nursing station has Wi-Fi. So we're like, great, you have a Wi-Fi signal, you can still transmit images, you can still FaceTime if we need to do something, we can still do live teleguidance if needed, and the signal's great for that. So again, there's ways and the technologies there nowadays that to support this.
You want to briefly touch on some of the early strategy that you had to try and implement that there was POCUS function in those rural areas? What specifically was a key to get that process started?
Yeah, for sure. I think a lot of it stemmed from actually the COVID pandemic. So one of the, I guess, good things that came from the pandemic was, again, a lot of these patients were being sent out and, they're just short of breath and presumably have some type of pneumonic process. And we found there's a small bit of them that were having, some cardiac dysfunction as well. And their management was a little bit different, or where they were going to be going was a little bit different with the depressed cardiac function. And so the idea was, why not put the probe rurally into these places, allow access to POCUS expertise, and we quickly were able to train a small group of people. This included nurse practitioners, nurses, and physicians, and virtually all of them had zero to no previous POCUS experience, and so we're able to train them up over a level where they can do a very basic cardiac scan, they can do a pulmonary scan, and do some basic interpretation and let that guide their treatment. And it also allowed us to start triaging patients which needed to move out sooner, right, during kind of peak waves of the pandemic. So again, that triage tool is pretty powerful.
Man, so many questions for you.
Oh, gone. Just two things. One, I think someone asked around the study. Is it possible if I post that into the chat? Is that viewable by the participants? Or yeah, I'll do that. The other thing I was going to pick up on was just around you said about quality assurance and feedback. I think that is the most powerful tool for education, is the ability to feedback on two levels. One is the sort of baseline quality assurance by a provider or a reviewer. So, do you have inter-observer reliability between the reviewer and the person that's captured the image and interpreted it at a scene around their findings? And then if you can then augment that with hospital level follow-up, which for various different reasons is still a bit of a challenge within the UK system. It's not as joined up as you might expect. But if you've then got that second layer, did that positive EFAS turn out to have free fluid on the CT, and what did they then go on to have? Did they have a damage control laparotomy like you expected? Is really, really valuable and the most powerful tool, I feel, for improving both compliance with uploading the studies and completing the entirety of a protocol, but also in terms of giving that guided feedback and points for improvement. Just means that you have an engaged group that are willing to continue to learn with POCUS. So it's very much a two-way process. You need the users to upload quality studies with sufficient clinical background information, and then you need depth in the quality assurance and full complete feedback in order to help that development. So yeah, that's definitely been a really powerful tool for us, I think, in terms of building our system.
And you just implemented a software system where you have a higher level of feedback and of documentation. That was something that you just published.
Yeah, so that's what I'll link into the chat. But yeah, using a quantitative sort of scoring system, using the Butterfly software to actually give a sort of score associated with your study quality, and then using the tools within the QA functionality to then sort of work out where that reaches the standard for sign off. And I think that was another question in the chat as to then competency. Yeah, so it very much depends on where you're heading towards and your progression through your dashboard in terms of how many studies you've done, but what quality of those studies been. And ideally, what we want to see is improvement over the course of, you know, those 20 studies, let's say, normally for say cardiac arrest scans, and ideally a range of pathology as well. I think that's the other key, is 20 clips all showing cardiac standstill probably won't be enough to say you're fully accredited in pre-hospital POCUS for echo. So we need a bit of a range of different pathologies, ideally as well. And some can be in healthy subjects, some can be done in simulation and training settings as well to contribute to that total. We'd also put the training studies through the same QA process as well.
Yeah, to me, it's so interesting and really empowering to hear you guys talk about the fact that how you're messaging about what the breadth of the potential for implementation of POCUS in this environment is, really, like, you know, saying the fact that people with different backgrounds, paramedicine, should be able to get to the stage of being able to do fairly comprehensive acute care assessment, and you guys being leaders in this area, being supportive of that, I think it's very encouraging. And then linking to the point about what Ben, you made the comment about the technology, right? The technology is already here. That's the interesting thing. The technology of, you know, talk about the ability of what we can now do when it comes to point of care ultrasound compared to even 5 years ago, Ben, that you said, that technology is dramatically improved. The connectivity component, I think, is really also interesting to hear you talk about the fact of the value of the connectivity for QA, for training. How do you bring in those components to be able to, you know, help decrease the burden that you guys we're all trying to do in terms of disseminating knowledge, but also providing feedback. And I think that connectivity component is also emerging and improving, and hopefully that's allowing us all to be able to you know, to kind of reach out further. Keep on going to the questions here.
Yeah, and John hopped on. Hello, John.
John.
Hopped off.
How you guys doing?
Great.
Great.
You have a question?
Yeah, let's go. So from another person from the attendee list, in the US, what are the legal implementations of flight nurse paramedics interpreting ultrasound? Peter, I mean, do you want to answer this, or for the US? I mean, it's a mixed bag, right?
Well, I guess we can get this out to a global level. Ultimately, this is a conversation that there's some areas where a physician is required, right? When what you're describing, Ben, but certainly in the US, it's really proof of competency from training. So it's not a physician-specific skill set. And so, and privileging and credentialing in the States is a local phenomenon. So that's going to be subject to whatever local, regional approval you can get. But in general, for instance, there are systems where medics, APPs, nurse practitioners are all can all be privileged and credentialed and be subject to the same legal, I guess, the legal risk and legal benefit by the fact that they have proof of qualification for doing point of care. So that becomes a local issue in terms of a region of what's accepted or not, and I think we'll segue really into, there's a question for Ben, which we'll start with, but also in general, it's the concept of how many studies are needed for someone to be competent or qualified, and certainly that seems to vary with what application is being talked about. But as you talk about legal protection or legal liability, part of it is what does it take to have a proof of competency? So Ben, you want to start with that from your end?
Well, I fully agree with what you just said. I mean, I can take you, Guillermo, and show you within 10 minutes how to scan an eye, and then I'm going to throw in 10 pictures of a retinal detachment, and you're good to go. And I think the same thing goes for the distinction between A lines and B lines. It's, you know, A lines is this, B lines is this. Go and have fun. The thing is, for example, in Austria, we have, there are, for the 3 German-speaking countries, Switzerland, Austria, and Germany, there is a they agreed on a joint concept of how many cases you will need to do specific things. And for example, for the EFASTs, they're asking for 20 EFASTs where 5 of them should show a pathology of what you did. Now go out in the pre-hospital field and find 5 positive Morrison pouches within a couple of months. That's ridiculous, you know. So I think we will have to think about that, but it shouldn't hinder us from just taking the probe and collect cases, you know. For example, in total for POCUS level 1, you will need 200 cases, 200 patients scanned. And there are, for example, 20 EFASTs, 20 DVTs, 80 cardiology cases. And from there, then you will have to review that with a level 3 sonographer, and then you'll get your certification. But I think, yeah, it's especially for the paramedics, it's just to take the probe out and put it on the patient and practice and practice and practice. And then to be proficient needs to be evaluated by somebody who is capable of performing ultrasound very good. So it needs kind of a final teaching, and then it needs kind of an ongoing support and kind of a bedside teaching. That's what we've implemented in Vienna. So there are different ways, and the legal standpoint in Austria is still not solved. So in Austria, ultrasound is still in the doctor's hand. Now we try to sneak our way around by telling we want to get paramedics as proficient enough to provide the doctor on the other end of telemedicine with high quality images. But I think I'm pretty sure that's going to be solved down the stream somewhere, you know, because this is just, you can't put it back in the box.
Yeah,
I'm sure there's an English expression for that.
When we established our system, I was keen that it was pre-hospital providers interpreting studies done by pre-hospital providers, because the risk, I think, if you don't use that type of structure and you don't look at the rest of the situation that the study's been captured in, so understanding a bit about the circumstances that the crew was in, especially for scene type jobs. The feedback then, the educational feedback, if someone's advising, well, what you're doing better doing is turning this patient into a left lateral position and doing this, well, that's not possible in someone that's in cardiac arrest or is in spinal immobilization. So it's just important that you contextualize the feedback and the potential learning in the context of the situation the crew found themselves in, and the people that can understand that best are those that do the job and respond to these types of incidents on a regular basis. And also one of the most important questions that I set in our sort of question set was, what was the question that you wanted POCUS to answer? And if you can't articulate that question as a user, then you're just playing with the probe, right? So really important that in the sort of submission of not just the images, but also the clinical justification as to why they were using the probe in the first place, and ideally should be able to articulate the specific question. That's a good standpoint, I think, for feedback.
I think it's quite similar to ECG interpretation. Nobody would ask how many ECGs do you have to see to interpret it the correct ways. Of course, there's easy rhythm problems that you can identify with a blink of an eye, and I'm pretty sure that all of you guys sitting here do have these ECGs where they look at it and you think, what the hell is going on here? And then the big cardiologists come on there, well, you got to interpret this, and this doesn't look so familiar to me. So it's just, I think, a skill. And our paramedics, for example, are trained to detect an ST elevation, myocardial infarction. And they started at one point, and of course there was lots of insecurity at the beginning. And now, when I'm in my shifts and they call in and listen, I just sent you an ECG. Could you have a look at it? I'm not too sure what's going on in this lead, because if you look at this lead and at this lead, it's like this and it's like this. And could it be a hyperkalemia? And you're sitting like this. You're sitting there and you think, where the hell did they get so proficient in ECG interpretation, you know? So it's a process, and it's just all about starting it.
Progress.
That's what I say.
Get through some of these. Jacob asked about the trauma triad dictates we consider temperature loss. Does that play into ground versus flight scan? I'll let our panelists, does that question?
We're all from cold climates, so yeah, I think we can all speak to this probably.
All right.
Yeah, we intentionally kind of said, yeah, if it's a scene call and you have an injected patient and it's, negative 30 degrees Celsius, probably not the ideal time. Conversely, if you intubate someone, you need to check for lung sliding bilaterally or decompensate while you're still in the field, then reasonable to do so. Try to pack those guys up and scan them in flight where you got heat going on them. So the gel is cold, can't do anything about that.
The good news, you can do some really good optic nerve sheath diameter because that gel's so stiff it can pile right up over the globe. Saves you having to have that special mini fridge in the helicopter for the gel.
Yeah, we sort of briefly discussed sort of in-flight scanning. We certainly have used that, especially on the procedural side. Someone's struggling for access, doing the IV access in the aircraft, or on the road ambulance. Actually, our sort of thinking is if the ground transport's going to be 45 minutes or less, with the load phase and the unload phase at the other end, because a lot of our hospitals don't have sort of rooftop pads and require a secondary transfer, that actually, unless it's a less than sort of, if the journey by road is going to take 45 minutes or less, then actually probably as well off just going on the road ambulance, and then you've got lots of capacity to be able to do ultrasound en route, while staying restrained within the back of the vehicle, etc. But yeah, you can easily get across and reach even into the left upper quadrant. Our ambulances tend to load with the patient's left-hand side against the bulkhead. So the combination of the scoop usually and the bulkhead makes the left upper quadrant slightly more challenging, but it is doable.
John.
Yes, sir.
Would you have a question or comment before we're going to wrap up? But
no, I'm trying desperately to get, as my usual crew is trying to participate in this webinar, which has been a little bit of a struggle to see a little bit late. But I think the point that was made, which I think is an important one, and we tend to, both as a professional society and as physicians, hold on to this skill set that we have as if it's some sacrosanct thing and nobody else can do this but us. But the data has been clearly shown, and I don't care which thing you start with. I love to talk about, if you think about cardioverting somebody, we're old enough to know that you nearly had to be one person in the hospital was allowed to do that because they had special training. Now in a gymnasium, a passerby can do it. And the same thing went on with glucose. There was a time even with stool guaiac that you had to be a certified person to be able to tell that the color changed. So I don't necessarily think ultrasound skill, listen, there are obviously situations where they're above that, but I think at some point here in history, we got to figure out that other people can do this stuff other than doctors. It serves everybody's interest to do that. And particularly when you're talking about transport and EMS, I mean, just think of what kind of impact it has activating a STEMI on an ambulance versus waiting for the hospital. The same thing will happen with ultrasound if we're getting good at it. AAA is diagnosed in the field so that you have a hypotensive patient and the OR is ready when you get there. So I think you guys are leading this, but I think we got to kind of sum down, and I say this with all due respect, our high horse, and know that people can be trained in this stuff, and they're not going to get trained unless we start letting them do it. And we can put in some guidelines, but those guidelines should not be so arduous. It doesn't take 250 scans to know the difference between an A line and a B line.
Well, and frankly, as we're going across international worlds here, the reality in North American pre-hospital medicine is that we don't have doctors in the field, and we have long transport times. And if you want to take good care of a patient, you have to offload that ego that only certain people can do the imaging, because the earlier it gets done, the better the chance that that patient has the information for a different outcome.
And they do just one more point, but they also do probably one of the most riskiest procedures I think in medicine is intubation in the field, sometimes in the most ridiculous circumstances, and they do it, and they can do it pretty well. So to say that you can't touch a probe is, again, just kind of ludicrous.
Right. You're picking which critical skills actually has
Right.
more value than the other. So unfortunately, this I can do this for hours. It's just wonderful having you all. We have 5 minutes left. Would like each of you to, I guess, a parting tidbit or parting pearl for our audience and listeners on your world of pre-hospital point-of-care ultrasound. And thank you all so much for joining and just really for a fascinating conversation. And those who have asked questions that we haven't gotten to, we will get to them after this and get back to you. So thank you all for putting in your questions. So I'll go in reverse order. Tom, we're gonna start we're gonna go counterclockwise this time. So again, thanks.
Thanks again for having me. I think my big piece of advice is if you're going to roll this out, I don't think there's a one size shoe that fits every HEMS or ground EMS transport system. I think you need to analyze what exactly what are you transporting? Is it mostly medical? Is it trauma? Are you dealing with scene calls or IFTs? That's kind of the first step. So survey that, know what you're dealing with. Look at what your crew complement is, right? So, are you a physician medic, physician nurse complement, or nurse medic, whatever that complement is, and then tailor that education, right? Again, not to knock our paramedic colleagues, but their anatomic understanding isn't the same as a nurse or physician, just that's not part of their education. So again, tailor that educational content to what their background is pretty key. Ensure that they're supported. So yeah, when you're rolling this out, it sucks getting texts at random hours of the day to look at clips and things, but that's a part of this. So make sure your crews are supported, that you have a good QA program, and pick a device also that fits what your transport environment dictates. Sorry,
Awesome.
that was a lot.
John.
That's
great. Great. Wonderful. It's perfect. John.
Yeah,
No,
so I think so other John.
No, the important John should go first.
I think for me, the biggest thing is to make sure that you make your, when you're going to launch ultrasound, make sure that it's the best system you can manage. Because if you do a soft launch and then try and retrospectively then build on all of the other aspects, it's much harder than if you really take the time to think through all of the different aspects, whether that's training, quality assurance, the type of device, how you're going to implement it, what protocols you're going to use, and then do a really, really thorough end-to-end considered launch, then you'll be much more successful. I've worked with systems that have done the sort of soft launch, they've just bought the probes and then put them on the vehicles, and then now trying to shoehorn all of the other aspects, it's much more challenging. And the other thing would be just to make sure the quality assurance has got the most depth you can possibly do. Invest in your faculty. The more they feel invested in the system, the better quality the quality assurance will be, and then the more engaged the users will be to continue to learn and develop with POCUS. So 2 things.
Ben.
Yeah, I think when we go back to the roots of POCUS in 2014, Solomon and his colleagues, they did they formed this phrase, "Stop listening and look," after they had experienced stethoscope users compete against medical students with point-of-care devices. We all know this study, and the cardiologists didn't stand a chance at getting the diagnosis faster. And I think today we know that point-of-care ultrasound is far superior to so many traditional methods that are deeply implemented within, for example, the primary assessment. So that's why I believe we need a radical shift in thinking. The ultrasound device needs to come out of the emergency bag into the hands of any healthcare professional using a stethoscope and put to use. And my dream is that by 2030, every experienced paramedic will carry an ultrasound device with them. And maybe in 2024, 10 years after Solomon published this study, it's time to say, after stop listening and look, to stop stowing, carry, and use. If that makes sense.
I think, that's mic drop sort of a comments there. It's pretty good.
Scan, everyone. We're out of time.
I'll leave you one here real quick, and that is and ask every one of you and think of it. If you went down and the paramedics had to show up at you, don't you want them to have that skill? I mean, I literally went to my fire department and said, I live in this neighborhood. I'm an old guy. I want you guys to have this skill because if I go down, I want you to have it. So let's get with it. And I think that actually they looked at me and they go, okay, doc, we'll learn. But at the end of the day, that's what we want. We know it's better medicine. So, you know, I encourage all of you out there that are listening to this. Obviously, it's a little bit like preaching to the choir, but I think that's really the message. We know it's better. We want it for ourselves. We want it for our patients. So we just got to kind of get off the dime and take the advice of these great experts on how to move it forward.
Agreed.
Yeah. Peter, you want to close this out?
You close
Oh,
this
man.
out. How's that? What's that?
Well, yeah, I'm happy. Yeah, I mean, I think, you know, what a great discussion, right? The fact that we'll follow up again to what Peter said about the remaining questions. I think, you know, just seeing the feedback, I think our audience really enjoyed hearing your comments and resonated so much with, you know, you saying how this is approachable and there's a way you have to find it. We're all discovering how to get it out there, right? And try to get it to the people that we know it can do and provide, you know, the quality of care we want to deliver now that the technology's here. And, you know, again, I really appreciate everyone sharing your stories and your journey. We're all on the same journey of how we can advance healthcare, and this is one of those steps to do it.
Agreed.
Perfect.
All right, with that, thank you
All
guys.
right.
Oh,
Good
and
night,
thank you.
all. Thank you.
Yep.
Thanks for having us.
All right.